Just start. Kanchan. Kanchan is speaking. I can't hear you. Hello.
Yes. So hello everyone. Today we are going to start our journal club program. So first I would like to introduce our Dr. Lakshmi Shikhande ma'am. I invite ma'am as a chairperson I would like to invite ma'am and ma'am is the chairperson of IMS Education Committee, and she is the medical director of Shikhande Fertility Clinic, Nagpur, Maharashtra. Over to you, ma'am.
Kanchan, thank you so much. You can stop your screen sharing. Friends, as chairperson ICOG, I welcome you all for this journal club. And this journal club is a theme based, and the theme for today's journal club is poor responders. So I take this opportunity to thank our FOGSI ICOG president, Dr. Rishikesh Pai, Secretary General, Dr. Madhuri Patel, and I like to welcome my ICOG office bearers, Parag Piniwale, who is Vice Chair, Ashok Kumar, who is Secretary of ICOG. Then we have Suvarna Khadilkar, who is Editor Emeritus of our Jogi Journal, Geeta Balsarkar, who is sitting Editor-in-Chief. And I also welcome our international expert who has logged in for this journal club. The conveners for this club is Chamila, but she is held up in some emergency. So till she joins, Kanchan will be managing the show. And I welcome Dr. Deepak Goenka, who is the coordinator, and MOC Dr. Kanchan Murarka. I also take this opportunity to welcome all our presenters, Dr. Rojina, Dr. Dhiren, and Dr. Saurav, and all 5 experts, that is Dr. Abukar, Dr. Deepak Goenka, Dr. Fesi Luis, Dr. Kanchan Murarka, and Dr. Pratik Tambe. So friends, I am sure this journal club will throw light on management of poor responders, and it will be a great learning experience for we all. And I hand over back to Dr. Kanchan to start the academic program of this journal club.
Thank you so much, ma'am, for the introduction. So now I would like to invite our coordinator, Dr. Deepak Goenka, sir. Sir is the consultant.
Unka slide dikho.
Yeah, ma'am, it's not showing.
Just move your slides. No problem. You just invite him. Yeah.
Ma'am, 1 second. So first, I would like to invite Dr. Deepak Goenka, sir. Sir is the director of Institute of Human Reproduction, Guwahati, and he has been doing IVF since 1997 and has performed more than 25,000 IVF cycles and has trained many IVF experts. Sir is also the president of Assam chapter ISOBA. Then I would also like to introduce our Dr. Sharmila ma'am. So. Ma'am is the Vice President of Elect FOGSI 2024, and she's the Chairperson Clinical Research Committee. Ma'am is also the Joint Director of Getosis India Association. So I would like to welcome ma'am. Then we have our President Sir, Dr. Rishikesh Pai. I'm very thankful to President Sir, Dr. Rishikesh Pai for giving us this opportunity. So Sir is the FOGSI President of 2023 and the FOGSI Secretary General. I would also like to thank Dr. Parag Piniwale. Sir is a senior consultant of Gynae Pune, and he's a PG teacher and unit head Kamala Nehru Hospital. I would also like to thank Ma'am Madhuri Patel, ma'am, Secretary General of FOGSI. Ma'am is the Secretary General of FOGSI and Joint Secretary of FOGSI 2009. Then I would also like to thank Dr. Ashok Kumar, sir, Secretary of ICOG. Sir is a Director, Professor and Head Department of Obstetrics and Gynaecology, Atal Bihari Vajpayee Institute of Medical Sciences and Dr. Ram Manohar Lohia Hospital, New Delhi. Then I would like to thank Dr. Suvarna Khadilkar. She's the Deputy Secretary General FOGSI and editor of Emirates. Ma'am is a professor and head Department of Obstetrics, Gynae and consultant endocrinologist and gynecologist, Bombay Hospital. I would also like to thank Dr. Geeta Balsarkar, ma'am, editor-in-chief of Jogi. Ma'am is a professor and head department. Ma'am is the editor-in-chief of Journal of Obstetrics and Gynaecology of India for 2021 to 23. Ma'am is also the treasurer of Mumbai Obstetrics and Gynae Society. So I would like to welcome ma'am, Dr. Geeta Balsarkar. Then today we have with us all the experts where we have international as well as national faculties. So I'd like to welcome all, and I would like to introduce our expert, Dr. Abu Bakr Muhammad Il Nasher, sir. He's our international expert today. So he's a professor of Gynae, Behna University Hospital, Egypt. He's the president of the Clinical Society of Obs and Gynae, member of Egyptian Board of Fertility Sterility Society. Sir is the international reviewer of ASHRAE guidelines for many gynecological conditions. Sir is also the editor of many reputed journals, and he has more than around 41 international publications. Sir has been a speaker in many international conferences and national conferences, invited speaker in many countries throughout the world. Sir has also around 606 lectures on SlideShare, and sir is the author of many books and co-author also in many books, and he has contributed a lot. So today we are very much privileged to have such a knowledgeable person amongst us. Then we have our national expert, Dr. Deepak Goenka. I have already introduced sir. Then we have with us Dr. FOGSI Lewis. Sir is the professor and head HOD Department of Reproductive Medicine and Surgery, Amrita Institute of Medical Sciences, Kochi, Kerala. Then we have with us Dr. Pratik Tambe, sir. So sir is the ART consultant and gynae endoscopic surgeon, Ashirwad IVF, Mumbai. Sir is also the international diploma in advanced laparoscopic surgery and is trained in assisted reproduction from Belgium. And today we also have an expert, myself, Dr. Kanchan Murarka. And then we have with us presenters. Our presenter for today's article are Dr. Rojina Manandhar. She's from Nepal, and she is currently doing fellowship in IHR. We also have with us Dr. Tanya Das. She's also a presenter for the article, and she is also doing a fellowship with us in IHR. Then our third presenter is Dr. Saurav Maheshwari. Dr. Saurav Maheshwari is working as a consultant in IHR. So I would like to invite Dr. Deepak Goenka to give the introduction to the program.
Thank you, Dr. Kanchan. I think nobody introduced you. Let me introduce yourself first. Please put up your slide, your CV slide. Dr. Kanchan Murarka and myself, we are working together since last 10 years. She is currently senior IVF consultant at IHR Guwahati, and she is doing an excellent job. And thank you, Kanchan, for introducing all of us. Let me talk a little bit about this ICOG program. This is brainchild of Dr. Lakshmi Srikande, ma'am only. Once she took over the ICOG as a chair, she thought of conducting some academic activity, and she started this ICOG Journal Club. The first Journal Club was conducted on the 13th December from CMC Vellore about the preterm birth. Second was conducted from the KE Mumbai. And third Journal Club was conducted by All India Institute of Medical Sciences, Delhi. And this is the fourth Journal Club which we are conducting here at IHR. We are thankful to the organizing committee for giving us this opportunity to conduct this Journal Club. And we decided to talk about poor responder. we all understand, all who are practicing infertility and conducting, performing IVF, we all understand how important this chapter is. This is a problem every day we face. Sometimes we are able to predict some cases we are not able to predict. And on the top of that, to add confusion, there are 101 definitions of poor responders. Bologna from Italy, the group there for the standardized the thing. But again, there was significant variations were there. Then the Poseidon criteria came over, and still we are a long way to move forward to understand poor responders completely. We decided to look up a few articles about the poor responder, how the things are moving forward. And Dr. Rosina, Dr. Dhiren, and Dr. Tanya, they decided to present some of the important articles which we felt are relevant in today's date. And apologies from Dr. Dhiren Datta. Because of sudden illness, he is not able to join us today. So instead of Dr. Dhiren Datta, Dr. Tanya is going to present his presentation. I think without wasting much time, we can move forward, Dr. Kansan.
Thank you, sir. Thank you so much. So now we would like to start our academic session. So our first article is update on the management of poor ovarian response in IVF, the shift from Bologna criteria to the Poseidon concept. And this article will be presented by Dr. Rosina Manandhar. So over to Dr. Rosina. Dr. Rosina, are you there?
Hello.
Yes, Rosina, we can hear you.
Respected national participants, I am Dr. and in HR, and to be a part of join FOGSI ICOG. And your day's theme is ponder. Right.
Rosina, we can't hear you.
We're seeing the slide, but not a sound.
Okay, sound. Is it?
Rosina, can
audible?
Rosina start? We can't hear you.
Is it?
Slide we are seeing, but not the sound. You do one thing, Rosina. You close your video, then the bandwidth may be less.
Or you can shift into some other room also. You can go to Dr. Kanchan's room. I think reception is better in Dr. Kanchan's room.
Or you make your video, then the sound will be better.
Is it audible?
Yeah.
Yes.
Rosina, start.
Please start.
Today. Okay.
Rosina, come to my room
We have all
immediately.
know.
His voice is breaking.
Rosina, you can come to my room also.
हाँ लेके आओ फटाफट लेके आओ Then I going to my room. Just hold it for 1 second.
Okay, today I will be presenting about the review article, update on management of poor ovarian response in IVF, the shift from Bologna criteria to Poseidon concept. And there are 8 authors of this article. Main author is Dr. Panagiotis Dracopoulos, who is a visiting professor and senior fertility specialist at Center for Reproductive in Belgium. And he's also working in University of Crete, Greece. He has authored more than 90 reviewed papers, and his research focuses mainly on the poor ovarian responders. This review article has been published on 2020 Therapeutic Advances in Reproductive Health in volume 14, and it has been cited by 28. And this Therapeutic Advance in Reproductive Health is an international peer-reviewed open access journal indexed in PubMed and Web of Science. According to this article, poor ovarian response is a major challenge to both fertility expert and the patient, and it accounts for 94%, that is 1 in 4 patients undergoing stimulation in IVF. So this article has a
Dr. Deepak, your voice went off.
Deepak, we are not able to hear.
Kanchan, can you give her a call?
Yes, sir. Yes, ma'am.
Someone else can present otherwise if audio visual is so poor.
Or Rogina, you can use the audio from Deepak's this thing room.
Dr. Deepak? Kanchan, what happened?
Ma'am, we are looking into it. So sorry for the inconvenience. Just 5 minutes, ma'am. I think some network issues going on, ma'am.
Okay. Okay. Dr. Fesi, you're there?
Yes.
Like for a poor responder, you think this Bologna's criteria or the Poseidon concept has a meaning for a clinical practice?
I think to some way to decide the stimulation, it will be useful. Yes, Deepak is back.
But how do you base your stimulation on that, sir?
No, that is only one criteria only. We had to look into the other antral follicle count, FSH value, everything we had to see. So this will help in anticipating whether with the response in some cases, so that we can plan whether the patient can go for a poor responder or not.
Do you check for FSH polymorphism in your
No. That is, I think there are only few centers in India doing that, but that is a promising thing. But if we can have available widely.
Suppose you have an unexpected poor response for a so-called normal response, who looks like will have a normal response. What will be your next strategy to get over that?
So we have to really see how the next cycle we have to counsel about and anticipate poor response and go for usually we go for adjuvants in the cycle. What are the few adjuvants which has been really found to be out of that? We'll be discussing that. One is the growth hormone, at least few data is there, and one is the testosterone gel, little more less data is there. So we can try that, even though most of the people use DHA also, but DHA, there is no larger studies are there.
But so what do you think will work better? Because in your center, I know you are a great proponent of growth hormone and you've given good results also. So, but it's quite expensive. But no, is it worth?
The thing is that most of the Western studies is with the growth hormone using 8 units or 12 units.
Okay, sir.
We have been using for last maybe 10 years using with 2 units of growth hormone, okay, and reasonably good result with that. Along with that, poor responders you have to use with HMG along when we start with the stimulation. And there are cheaper growth hormones available in India, although it is off-label use. Like 2 brands are there, which has 1 unit cost about 75 units of HMG cost. So 2 units means okay, it will be equivalent to additional 150 units. So don't use more than 450 of HMG, 300 or 450 with the growth hormone. That will be reasonably good result. I think that the larger study we needed to really tell that, but at least few for whatever the antral follicle what we see we will get. We won't get a more number of follicles than antral follicle, but in poor responders, especially the cases which you are telling about what we are anticipating good response and it was a previous bad response.
Okay.
In those patients we can try in next cycle after using the by using the growth hormone.
When do you start it?
Along with that stimulation.
How long will you continue?
Till the day of HCG.
Same time as the stimulation dose you can give, or different time you should give growth hormone?
The same time. Same
time. You can give. 2 units with the 450 HMG. 450
HMG. Poor responders.
Okay.
And it has to be HMG, not. I mean, otherwise the cost will go up further.
Yes, sir. Will it be an ANTAC protocol or against protocol?
ANTAC, I usually go for ANTAC only for hyper responders.
Okay.
So long protocol, I prefer to go for long protocol. Even though nowadays the initially ANTAC was told for hyper responders and poor responders. Now in more and more Western studies are coming for poor responders or normal responders. They can go for ANTAC and long agonist also. So in poor responders, when we go for ANTAC, but minimal suppression, you will get a uniform number of follicles. Okay. We will get better yield. Or we can use ANTAC also, antagonist also.
Will a mini dose long protocol work better than a regular long protocol?
Pardon?
A mini dose. Because she's a poor responder, would a mini dose be better?
I have no experience with that because previously, before ANTAC came, we used to do the short protocol. That is not at all found to be getting good results.
Okay. I think Dr. Rajina has joined back. Are we ready? Can we do that? Dr. Kanchi? Dr. Deepak?
I think we are ready.
She can screen share then and start.
I think somebody has to enter for the unmute her.
Sir?
Unmute her. We have to unmute her.
Please unmute her. Tech support. Her name is Regina, I would tell you.
Dr. Rojinda Manandhar.
Just show your video, no, so that I can unmute you.
Yes,
right,
please.
right. I just unmute. Can you try now? Where is tech support? Natalia? Natalia, unmute her, please. Yes.
Now it's coming?
Yeah.
Slide is coming?
Yeah, you can screen share. You're audible also. Screen share.
Really sorry for the network.
No problem. It's all accepted.
According to the article has mentioned.
No, screen share. Your video.
Okay. Okay.
Something wrong here. Just give me 1 minute.
Okay, sir. Because the mini dose for a poor responder, they say will not cause so
Pradeep
much of
Tambe has
downside.
also joined. He has written a comment.
Okay.
Pradeep, are you there?
Pratik, you can unmute yourself. I think
Yeah,
the
I'm
tech
here on the
support.
road. I've just
Okay.
finished at the FOGSI office, so there'll be a
Okay.
lot of disturbance in the background.
Okay.
I just wanted to say that most protocols, you will end up generating 2, 3, or maximum 4 oocytes only,
Okay.
follicles rather.
Okay.
And when you retrieve them, it is the quality of the oocytes and the fertilization potential that matters, which governs your results.
Okay.
Most protocols, you will be able to generate the same number of follicles. As Dr. Fesi was pointing out, addition of growth hormone or transdermal testosterone gel
Okay.
helps to increase the quality of the oocytes.
Okay.
The quantity may not necessarily be different.
Okay.
So there are different ways of reaching Rome, as it was said, but all roads ultimately lead to Rome.
Okay. Thank you, Pratik. I think the presenter can start.
Yeah, Rojina, please start.
Okay, so according to this article, the etiology of poor responder has been mentioned like age-related depletion of ovarian follicles, advanced endometriosis, chromosomal and genetic alterations, prior ovarian surgery, pelvic adhesions, autoimmune and infectious diseases. So a systemic review done in 2011 gave a shocking number of 41 definitions of poor responders. So ISRE in 2011 introduced Bologna criteria to reduce this vast heterogeneity definition of poor responders. So to meet the Bologna criteria, there should be at least 2 of the 3 features: advanced maternal age equal to or more than 40 years, abnormal ovarian reserve test, and previous poor ovarian response. In absence of advanced maternal age or abnormal ovarian response test, a patient can be defined as poor responder after 2 episodes of poor ovarian response following maximal stimulation. So in this article, it has mentioned that Bologna criteria has been criticized for several reasons, like lack of clarity in defining risk factors, lack of accountability for oocyte quality, and a significant degree of heterogeneity even within Bologna population. So groups can be formed within Bologna population with diverse prognosis, and this article has shown that clinical prognosis for younger Bologna population is better. And none of the treatment modalities has been shown to be effective in cases of Bologna population. So there is reluctance of fertility experts to use this Bologna criteria for poor ovarian response studies. And that's why in 2016, Poseidon Group has introduced a new classification, which is Poseidon classification. It is patient-oriented strategies encompassing individualized oocyte number. According to this Poseidon criteria, there are 4 groups, group 1 to group 4, based on quantitative and qualitative parameters such as age and expected aneuploidy rate, ovarian reserve biomarkers, and ovarian response. And from clinical point of view, it has been classified into 2 main categories: unexpected poor responders, which includes group 1 and group 2 patients, and expected poor responders, which includes group 3 and group 4 patients. And this article has beautifully done SWOT analysis of Poseidon criteria. The strength of this Poseidon, according to this article, is that it has included both qualitative and quantitative parameters in this criteria. It has done better stratification of low prognosis patients, more homogeneous subpopulation of low prognosis women. And weakness of Poseidon, according to this article, is that there is lack of clinical validation, inter-observer variability for AFC measurement, and variability in AMH level measurement. And opportunities provided by Poseidon are conduction of studies and evaluation of treatment modalities in different groups, recommendation on management according to clinical prognosis, and it has provided ART calculator, which helps in predicting the minimum number of oocytes required to form at least one euploid blastocyst. But the threats in this criteria are risk of reluctance to use by clinicians, poor recruitment of the patients, and cost effectiveness. According to this article, group 3 and group 4 patients has been grouped under expected poor responders, and group 3 patients are those with age less than 35 years, AFC less than 5, and or AMH less than 1.2 nanogram per ml. And group 4 patients are those with age equal to or more than 35 years with AFC less than 5 and or AMH less than 1.2. And group 3 patients accounts for 10% of the patients undergoing IVF, and group 4 patients accounts for 55% according to this article. And it has been mentioned in this article that in today's society, with increasing age of first maternity, group 4 can be up to 76%. Expected poor responders management has been listed under these headings in this article. Now coming to pituitary suppression regimens, meta-analysis done in 2011 and 2017 has shown that there is no evidence of difference in ongoing pregnancy rate between GnRH antagonist and agonist group. However, the randomized control trial done by Sunkara et al. In 2014 has shown that there is non-significant increase in number of oocyte by 1 oocyte in cases of long GnRH agonist protocol. And similar results has been shown in GnRH antagonist cycle where pretreatments were used, like estradiol pretreatment for 5 days, or GnRH antagonist pretreatment, or oral contraceptives pretreatment used for 12 to 14 days. Coming to types of gonadotrophins in expected poor responders, there is insufficient evidence to favor the use of one type of gonadotrophin over another, according to this article. And it has mentioned that addition of LH is beneficial in cases of poor responders. Similar result has been shown by systemic review done in 30 studies in 2018, showing the benefit of recombinant LH in the women 36 to 39 years of age. Now coming to the dose of gonadotrophins, randomized control trials and large retrospective study done in more than 600,000 cycles has shown that increasing the dose of recombinant FHS above 300 IU doesn't benefit in terms of live birth rate. Possibility of using mild stimulation in poor responders has been recommended by ASRM due to its lower cost and comparable low pregnancy rate. However, recent meta-analysis has shown that co-treatment with clomiphene, even though most economical, has lowest probability of resulting in pregnancy. Only advantages of natural cycle or mild stimulation in expected POR found in this article is patient friendliness, reduced duration and dose of gonadotrophin, and reduced overall cost. However, the live birth rate is very less, 2.6%. Regarding dual stimulation in expected poor responders, ongoing pregnancy rate in dual stimulation can be up to 20.7% in Poseidon group 4 patients, has been explained in this article. And the oocytes derived by luteal phase stimulation appears to increase the cumulative live birth rate, fulfilling Bologna criteria. Further detail about dual stimulation will be explained by my colleague Tanya Das. And Additional supplementations in expected poor responders has been mentioned in the articles, like androgens, including DHEA, testosterone, growth hormones, and coenzyme Q. Regarding androgens in expected poor responders, article has shown that a few small trials have been investigated, but with conflicting results. Recently, one trial, T-transport trial, is undergoing, which is using 5.5 milligram transdermal testosterone daily, 60 days pre-treatment in Bologna poor responders. After this trial, the exact dose and timing of pre-treatment will be clarified. Now, coming to the growth hormone in expected poor responders, addition of growth hormone in poor responders with growth hormone deficiency has shown to increase the higher number of retrieved oocytes. But however, randomized trial in 130 poor responders has shown no statistical difference in terms of oocytes retrieved between growth hormone supplementation group and control group. So more studies are warranted before the administration of growth hormone in expected poor responders, and optimal dose and duration of administration is still missing. Now coming to the antioxidants in expected poor responders, this article has mentioned one randomized controlled trial done in 160 Poseidon group 3 patients, which has shown significantly higher number of oocytes retrieved and less FHS consumed in those patients pre-treated with coenzyme Q for 60 days prior to ovarian stimulation. However, this article has mentioned that further prospective RCTs should be conducted to validate these findings. Other considerations in expected poor responders mentioned in this article is drug-free in vitro activation. This is an emerging and experimental technique. Study done in 2020 by Kawamura has shown an encouraging result of increasing AFC, increased metaphase to oocytes. However, it has been done in a small group of patients, so results should be interpreted with caution, and large randomized trials are needed to validate this experimental technique. Now coming to unexpected poor responders, group 1 and group 2 has been classified under unexpected poor responders. And these group 1 and group 2 Poseidon classes, though they have normal ovarian reserve markers, for several reasons they respond poorly. That means less than 4 oocytes are retrieved, or suboptimally, that means 4 to 9 oocytes retrieved following conventional ovarian stimulation. And the incidence of this unexpected poor responder is 40 to 45% according to this article. And it has mentioned that qualitative markers of ovarian response as follicular output rate and follicle to oocyte index. So patients with low full FORT or FOI less than 50% are expected to produce lower than expected number of pre-ovulatory follicles or oocytes following gonadotrophin stimulation. So according to this article, following causes has been mentioned as unexpected poor responders. The most important one is FHS receptor polymorphism. Others are polymorphism in LH receptors, asynchronous follicular development, low gonadotrophin starting dose, and technical issues related to final oocyte maturation trigger and oocyte retrieval. But whether FHS or LH receptor single nucleotide polymorphism screening should be offered to all the women with adequate ovarian reserve prior to their first IVF treatment is currently under debate, and further studies evaluating the role of polymorphism and their association with reproductive outcomes is to be done according to this article. And the details about this for FHS receptor polymorphism will be dealt in detail by Dr. Saurabh Maheshwari sir. Management of unexpected poor responders has been explained on the following headings in this article. Coming to the type of gonadotrophin in unexpected poor responders, this article has shown that use of recombinant FHS may be the gonadotrophin of choice for Poseidon group 1 and group 2 patients, as multiple RCTs and meta-analysis has shown that recombinant FHS is associated with significantly more oocytes. And comparable efficacy has been seen between GnRH agonist and antagonist protocol. So both can be used according to this article. Now, coming to increasing in the dose of initial dose of gonadotrophin, it is one of the most common treatment done in cases of unexpected poor responders, according to this article. And retrospective studies done have shown that increasing stimulation dose is associated with increasing higher oocyte yield. And each additional oocyte increases live birth by 5%. And this increase in initial dose of gonadotrophin is even beneficial in the patients with FHS receptor polymorphism. Similarly, addition of recombinant LH has also shown benefit in terms of oocyte yield in unexpected poor responders, and it benefits more in cases of polymorphism in LH receptor. And recombinant LH can be started in the mid-follicular phase in an attempt to rescue the ongoing cycle, or it can be started from day 1 of the following IVF cycle. Coming to dual stimulation in unexpected POR, it could be considered in cases of group 2 patients showing suboptimal response, according to this article. But however, disadvantages is that after dual stimulation, freeze only strategy is mandatory, and which may not be convenient to all the patients. Androgen supplementation. Study has shown that DHEA supplementation 75 mg per day for 8 weeks before control ovarian stimulation has shown higher live birth rate and low miscarriage in Poseidon group 2 patients. So this article has favored the use of androgen supplementation in group 2 patients. So by analyzing this article, according to me, this article has covered almost all aspects of poor responders, like from etiology to incidence to how it has progressed from Bologna criteria to Poseidon concept. It has also done SWOT analysis of Poseidon concept and classified the Poseidon into different groups and management according to the different groups. But there are few limitations. What I found in this article is that it has not clearly mentioned the subgroups within the group 1 and group 2 patients, and it has not mentioned about the individualized ovulation trigger, which we can use according to the protocols we are using, like in RH agonist protocol or antagonist, which ovulation trigger we have to use. And it has not covered about the dual trigger and pre-implantation genetic testing needed in cases of group 2 and group 4 patients who are more than 35 years, equal to or more than 35 years. Thank you.
You can stop sharing, Regina. Wonderfully presented. It was a great update of all the recent trends in management of poor ovarian response. But I think we'll take the next presentation and have a discussion of both, because I think that's going to cover dual stimulation. Is it okay, Dr. Deepak?
Yeah, ma'am, perfectly fine.
Okay. Can we have the second presenter? Kanchan, please introduce the second presenter.
Yeah. Thank you, Dr. Rojina Manandhar. Now we have our next article, and it will be presented by Dr. Tanya Das. The article is double or dual stimulation in poor ovarian responders. Where do we stand? So over to Dr. Tanya Das.
Tanya Das, show your video. She's there.
Dr. Tanya.
By the time they join, can I ask Dr. FOGSI and Dr. Pratik some inputs? Dr. FOGSI, she said in her update, she said like the type of gonadotropin matters for the Poseidon 1 and 2 groups. And you mentioned that HMG is better for those unexpected poor responders. But she said rec FSH is better, she said in her update.
No. The thing is that we can have to use LH. That is the main thing. And the cost factor is what we are concerned when in practical use. If you can get cost is not a factor, it will be a recombinant FSH combined with LH will be better. Only thing you need LH.
But if cost is not a factor, would rec LH give a better response compared to HMG?
Yes, because batch to batch consistency will be there. HMG, unless you are not careful, the batch to batch consistency will not be there, especially a few years back. Now the more and more purification techniques are there, more and more good brands are available. But otherwise, that is the main risk. Otherwise, definitely recombinant FSH, and that is why most of the foreign studies is with rec FSH, because
they can afford. They can afford,
and they go by that.
Okay.
Pratik,
yeah.
Okay.
I think FOGSI has touched a very important aspect. Out there in foreign articles, what we get is equally good results, whether it is a recombinant or whether it is a urinary result. Very rightly said by Dr. FOGSI, but in India, when we use recombinant, we definitely get little better result. It is because of the quality of the drugs what we get here.
Okay. Pratik, would you want to say something before we go on to the article presentation?
I would concur that most of the times our patients can't afford a recombinant FSH. But then if they are counseled properly, and if you explain to them that one good cycle with recombinant FSH is equivalent to maybe 2 or 3 cycles with highly purified HMG, most of them would lean towards recombinant FSH.
Okay.
This, of course, assumes that you're going to run one single cycle and you're not doing oocyte or embryo pooling.
Okay.
In most poor responders, you'll find that you'll get 1 or 2 follicles, 1 or 2 embryos. And if they are willing to wait, with embryo pooling, you will by and large get better results than doing a single transfer.
Kanchan, what do you would like to say?
No, I agree with sir, and I feel that when we are using recombinant FSH, definitely in group 1, 2, we are getting better results in our experience.
Is Abu Bakr sir has joined? We can have his international experience.
Dr. Deepak is joined. Sir is joined.
I think.
Dr. Abu Bakr sir, have you joined? Avis, can you give him a call, Dr. Deepak, by the time
I will give him a call and
Okay, the presentation can start. Dr. Tanya, you can start.
Thank you, ma'am. Good afternoon to the national and international faculties, and I thank you for the opportunity given to me to present in this journal club organized by FOGSI and ICOG. So today I'll be presenting the article titled Double or Dual Stimulation in Poor Ovarian Responders, and Where Do We Stand? This article was published in Therapeutic Advances of Reproductive Health in 2021. Therapeutic Advances of Reproductive Health, the journal was launched in 2008, and it is an open access journal, peer-reviewed and listed in PubMed with an impact factor of 1.7. The primary author is Dr. Mehtab Polat. She is a specialist at Anatolia Women and IVF Health Center, Ankara, Turkey, since 2005. Coming to poor ovarian responders, prevalence of poor ovarian responders varies between 5.6% to 35.1%, depending upon the differences in the definition of poor responses. So the first consensus was given by the ESHRE, also known as the Bologna Consensus Criteria, described in 2011. Accordingly, overall, the pregnancy rate attained with IVF in poor ovarian responder patients are very low, that is less than 8%. Polizos and colleagues in a cohort of 485 poor ovarian responders reported a live birth rate 1% in patients less than 40 years and only 5.2% in women who were more than 40-year-old. And they recommended pooling of oocytes and embryos. So this reportedly decreased the dropout rate of the patients and hence increased the cumulative live birth rates as well. So the first description of double stimulation was done in 2013, and a modified version of double stimulation coupled with pre-implantation genetic testing for aneuploidy, also known as dual stimulation, was given in 2016. So what is the physiologic basis of dual stimulation? As we all know that there are three distinct theories of follicular recruitment. The first one being the continuous recruitment theory, where small antral follicles, that is less than 4 to 6 mm, are recruited to grow continuously at all stages of reproductive life, and it is independent of gonadotropin stimulation. The second being the single recruitment episode theory, where a cohort of 2 to 5 mm follicles are recruited from continuous supply of antral follicles only once during each menstrual cycle. And the third theory is the multiple cohort theory, also known as the wave theory, where multiple cohorts of antral follicles are recruited during one menstrual cycle. So in a large population study, they showed that emergence of wave of 4 to 14 follicles measuring more than 4 to 5 mm were detected either 2 or 3 times during the interovulatory interval in a menstrual cycle. They concluded that 68% of women exhibited 2 waves of follicular recruitment during the interovulatory interval, and 32% exhibited 3 waves. So how do we perform dual stimulation or double stimulation? Double stimulation is performed in a single menstrual cycle, and it is composed of follicular phase stimulation and luteal phase stimulation. We can use either mild or conventional ovarian stimulation regimens, and these can be employed for both follicular phase stimulation and luteal phase stimulation. The mild ovarian stimulation could be biclomiphene citrate, letrozole, with or without use of low-dose exogenous gonadotropins. And conventional stimulation we can do by using exogenous FSH with or without adding LH or LH-like activity. Different strategies to avoid premature LH surge has been used in both FPS and LPS, that is GnRH antagonist use, exogenous progestins, or ibuprofen. And the most commonly used trigger is GnRH agonist trigger to finalize oocyte maturation for both follicular phase stimulation and luteal phase stimulation. No study till date has employed dual stimulation or dual or double triggering for either follicular phase stimulation or luteal phase stimulation during the dual stimulation. And a recent study has suggested use of GnRH agonist or recombinant HCG has shown better role than urinary HCG in both follicular phase stimulation and luteal phase stimulation. So the goal of this mini review article was to cover the available evidences which is published for dual stimulation in poor ovarian responder patients. The search procedure included the inclusion criteria were all the articles which were published as randomized controlled trials, prospective and retrospective cohort studies, case series reports, and the studies comparing the ovarian stimulation characteristics, embryological data, and pregnancy outcome between follicular phase stimulation and luteal phase stimulation in the same ovarian cycle. They used a PubMed database with the fixed keywords which have been listed, and their exclusion criteria included data published as abstract, meeting proceedings, book chapter, review articles, and article published in languages other than English. So finally, they included 12 studies comparing follicular phase stimulation and luteal phase stimulation in the same ovarian cycle. When we reviewed all the 12 studies, they found that out of the 12 studies, the 10 studies showed significantly more oocytes after luteal phase stimulation, and only one study, which was done by Bowden and colleagues, concluded that the luteal phase stimulation had significantly less number of oocytes as compared to follicular phase stimulation. Otherwise, all the rest articles have shown similar efficacy or better number of recruitment with luteal phase stimulation. Coming to the lab data and reproductive performance of follicular and luteal phase stimulation of the available studies, the number of oocytes retrieved were more in the luteal phase stimulation in all the 11 studies except by Bowden and colleagues, which showed a decreased number of oocytes retrieved during the luteal phase stimulation as compared to follicular phase stimulation. The fertilization rates, when compared between follicular phase and luteal phase stimulation, they were comparable in all the studies. Coming to the clinical pregnancy rate, the 6 studies which had seen the clinical pregnancy rate as an outcome, out of them, 50% studies showed better clinical pregnancy rate with luteal phase stimulation, and 50% showed better clinical pregnancy with follicular phase stimulation. When we compared the miscarriage or early pregnancy loss rate, the 6 studies that that viewed this as an outcome, out of them, 5 studies had more miscarriage rates with luteal phase stimulation, and only 1 study showed more miscarriage rate with follicular phase stimulation. Coming to the live birth rate when compared between the studies, the 4 studies which discussed the live birth rate between the 2 stimulation techniques, the 50% of the studies showed better outcome with follicular phase stimulation, and 50% showed better outcome with luteal phase stimulation. So there were only 4 available studies comparing the dual stimulation with follicular phase stimulation only. So they concluded that significantly less cycle cancellation rates were seen with dual stimulation, and significantly higher number of N2 oocytes, blastocysts, and cryopreserved available embryos were with dual stimulation. Coming to the discussion, they concluded that dual stimulation increases the number of oocytes when compared with follicular phase stimulation only, and the number of oocytes retrieved at luteal phase stimulation is either the same or higher when compared with follicular phase stimulation. Now, this could be because of many of the reasons which have yet not been concluded. The reasons being due to more synchronous follicular development, due to higher estrogen and progesterone levels during the luteal phase stimulation, or increased angiogenic factors during the luteal phase stimulation, or a flare-up effect of GnRH agonist trigger given in follicular phase stimulation, which acts on the luteal phase. Luteal phase derived oocytes have shown similar competence as follicular phase stimulation derived ones, including the fertilization, blastulation, and euploidy rates. Also, a recent study was done which showed that there was no significant differences in the mitochondrial RNA signature of the follicular fluid between the follicular phase stimulation and the luteal phase stimulation stages. The Delphi consensus concluded that dual stimulation should only be used when the need of obtaining oocytes is urgent, including patients with malignant diseases undergoing oocyte cryopreservation, patients of advanced maternal age, and patients with reduced ovarian reserve. Also, Eschrey in 2019 stated that due to the absence of adequate number of randomized controlled trials, comparing a double stimulation within the same cycle with mandatory postponed transfer and 2 conventional stimulations, they cannot recommend the double stimulation in poor responder patients. So the conclusion that can be drawn from this study is that future randomized controlled trials comparing 2 consecutive conventional ovarian stimulation techniques, that is 2 follicular phase stimulation only with dual stimulation, are warranted to delineate the role of this strategy in poor ovarian responders. Also, large-scale studies are warranted to delineate the features beyond classification as of poor prognosis to predict which couples might benefit the most from dual stimulation protocol. Also, the mandatory freeze-all and lack of cost-effectiveness data are the weaknesses of dual stimulation, and large-scale studies are warranted for the long-term safety of this approach. What I could derive from this article is that this is a systematic review of available data on dual stimulation in the last 10 years, and it is the first systematic review of its kind conducted on dual stimulation. The limitations of this article, according to me, was that it was just a mini review of 12 studies, and they used only literature which was published in English. They have not drawn any conclusive recommendations after the systematic review. Also, when they compared the 12 studies, all the 12 studies have used different protocols for stimulation during the follicular phase and the luteal phase. Also, they have used different triggers for follicular phase and luteal phase, and hence we cannot decide based on that which ovarian stimulation protocol can be used or which trigger has shown better outcomes. Also, all the studies have no fixed criteria to define poor ovarian responders in studies. And most of the studies, that is 7 studies out of the 12, are retrospective studies. With this, I come to the end of my presentation. Thank you.
Excellent, Tanya. You've done so well. Can you stop sharing?
Can we ask Regina one question first?
Yeah, yes, sir, please.
Regina,
Yes, sir.
what is the benefit or what is the main advantage you could see in that by the Poseidon criteria?
By Poseidon criteria, we are able to identify the poor responders into 4 different groups. Accordingly, with 4 different groups, we can management is different groups, so we can change the management. It helps in changing and the management in different groups.
The main thing, what I feel is that we can help in counseling the patient, because we can anticipate in the group 3 and 4, and 1 and 2. If you are seeing in the with the previous response, we can counsel. That is counseling part, and we can anticipate for response in those patients. That's the main advantage with that's one of the main advantage, I think, with the Poseidon criteria, which will be which is the main thing. So, Deepak, want to add anything?
You correctly said, FOGSI. And another advantage, if we are able to predict this particular patient belongs to this particular group, even the management can be planned beforehand, along with the counseling. And the management also can be planned, and we can tell the patient what to expect from with this particular management. Halaki, though we don't have a concrete management plan for each group, the article was chosen only because of that, because it discussed about all the possible management plans. What are the strengths of all different management plans? This is why we have taken this article to discuss.
So that international experts he has joined?
Yes, sir.
Abu Bakr, sir.
Dr. Abu Bakr. Does he need to be unmuted?
I think so.
Sir, can you on your video so that
if he shows his video, we can unmute him.
He told me he's joining.
Yeah, he told me. I just now. He was made a co-host.
So, Kanchan, can you make a call to him?
I just made him a call.
Yes.
He's here.
You can listen to me now. Good afternoon.
Yes, sir. Good afternoon, sir. Good afternoon, sir.
Yes, thanks a lot for this kind invitation.
Yes, sir.
And I think the Poseidon classification is very important. And as you mentioned, counseling of the patient and also the prognosis and the expected poor responder and the unexpected poor responder, there is a slight difference in the management.
Thank you, sir. I actually wanted to talk about Dr. Tanya's presentation on dual stimulation. And she mentioned the limitations also, because for fertility preservation, I can understand. You don't want to waste time and you want to pull the embryos and keep it for her. But why don't you wait for 1 cycle and do it again? What difference it makes if you do it in the same cycle or the next cycle for a poor responder? Dr. Pratik is there. Can you, Pratik?
Yeah, I'm here.
Yeah. So do you think there's an advantage of dual stimulation for a poor responder?
Yeah, as far as my knowledge goes, most of the studies on dual stimulation are in patients for fertility preservation.
Yes.
As she rightly mentioned, many of the studies which are included in the paper are retrospective studies, And there are ethical concerns regarding prospective trials in patients with poor ovarian reserve or poor responders.
Tanya,
Therefore, you will not find too many prospective trials. You will not find too many randomized trials. And we have to take the evidence as it is. And the evidence is inconclusive. So therefore, you offer your patients a choice. If they choose to go ahead with serial stimulation in a single menstrual cycle, that is fine. If they choose to wait and go in the next cycle, that is also fine. At the end of the day, what needs to be conveyed to the patient is that we need a certain number of follicles to give one euploid embryo, and that varies depending on which class of Poseidon the patient belongs to. That is the first counseling session which has to happen before you start even a single treatment cycle. When the patient has understood the ramifications of this concept, that you need X number of follicles or oocytes to generate one euploid embryo, that is when everything gets put into perspective. That's an important conversation that we should be discussing here as well.
Dr. FOGSI, what he said was like, it doesn't matter if you do it in a single cycle or in the next cycle. The cost effective factor is not there in dual stimulation. That's what she has mentioned in her that systematic review also. So,
Yes.
We can actually go for a fresh transfer for a poor responder. Doesn't it give better results than a frozen transfer?
the only thing, as Tanya was telling about the thing was, it is really indicated in patients we need less time. We have to those patients which we cannot buy time, those patients we can definitely go for a dual stimulation. Otherwise, it will be better for single fresh transfer and single stimulation, and subsequently going for a next stimulation. And another drawback of this study was that the number of patients in the each of the studies was very, very less. Some studies had only 2 patients. And so with that one result, we cannot tell that 50%. That is one drawback.
Yes.
That is otherwise, no. In the literature, if you don't have larger studies, we cannot conclude with that few number that luteal phase support is can be done. And as rightly Eshe was telling, it must not be advised for poor responders routinely. Only in the selected cases we have to advise that.
Have you published any studies on poor responders, Dr. FOGSI?
Not poor responders, but adjuvants were published about growth hormone.
Growth hormone. Dr. Abu Bakr, sir. Yes, sir. Dr. Deepak.
Yeah, now just wanted to know, we have used this dual stimulation, say almost 10 patients, and personally, I am not at all happy. Myself and concerned, both of us used in 6-7 patients, and myself and Dr. Sora, in fact, last month also, we used in one of the patients this dual stimulation. We got suddenly motivated by there was a surge of articles about the small articles. And we were motivated, and one patient was there. And none of the patients, I personally was ever happy with the second result.
Yes, sir.
FOGSI or Dr. Pratik, whether they have used it personally in any of the cases, they have their personal experiences.
I've used only 2 cases in my entire life. And very honestly, I can say that the experience was underwhelming.
I think it's same for all of us.
Dr. FOGSI, your experience.
Yes, that also only 3 patients. That results is not good. So that's why I think we are not routinely doing.
Dr. Abu Bakr, sir, what are your thoughts on the dual stimulation for poor responders?
Yes, we are not. It is rarely done in Egypt, and we should consider the cost, as you mentioned, and also the results of even transfer of one embryo. It may be better to cryopreserve it till the next cycle and to transfer more than one embryo. So in Egypt, we are not supporting the dual stimulation.
Thank you, sir. Like, will the trigger matter for a poor responder? They keep on talking about dual triggers for double triggers for patients with poor responders. Does it help?
Yes, we are doing the double stimulation, double trigger, And just I finished an MD thesis yesterday about the double trigger, not in the poor responder, but in the normal responder.
What is the dose
Right.
you give, sir, and what drugs
And
you give?
the result is better than the single trigger. Of course, it was done in the antagonist protocol, and the dose was given the decapeptyl 0.2 only as a double trigger with HCG 5,000 international unit. And it is good, or it is highly recommended in the poor responder, and also according to our study or the MD thesis yesterday discussed in Egypt, it is also beneficial in normal responder.
Dr. FOGSI, how do you give your dual trigger, double triggers?
I think routinely we don't give a dual trigger. So I think dual stimulation itself is very less. So I got less experience with that.
Double trigger. You don't give routinely double triggers.
Dr. Kanchan, I think you have given dual trigger in few of your patients.
Who?
Yes.
Dr. Kanchan.
Kanchan. Yes, Kanchan.
Yes. Yes, ma'am. I have been using this double trigger since quite a long time, especially in those patients where I see the number of follicles are less than 10, there where I'm not expecting any OHSs. Also, in those cases, when I'm giving double trigger, I'm getting definitely a better result. More number of oocytes are being retrieved, and better quality eggs and better quality embryos also. So I'm giving both lupride and injection HCG 5,000 at the same time, 36 hours before the pickup.
There's no time difference between your HCG and your
There is
agonist.
a question there. There is a question.
That's what Dr. Vidyun has asked. Yeah.
If there is a difference or the timing, it is not double, it is double.
Double trigger.
Okay. So
Yes.
It's not dual. It is
But
double.
we are
double.
giving it simultaneously in the same time.
Okay. And Pratik is saying a single trigger is even enough compared to a double trigger. Okay. And there's one more question by Dr. Yukti Bharadwaj, and she has asked, is the gonadotropin requirement in LPS same as a follicular phase? Yes, Pratik.
A simple recombinant HCG or orbital trigger will always give you better results, because the HCG component which is there gives you the best yield. All patients where we have been giving GnRH agonist trigger plus HCG trigger, because we're afraid that the GnRH agonist alone will not give us a good yield. This is a simple solution. In poor responders, you are not afraid of OHSS. So a simple Ovitrel is good enough. You don't need dual trigger in the vast majority of these patients because you're not afraid of OHSS, and it gives you good yield with excellent oocyte quality, which you aim for in the first place.
So
The
both
only thing-
yourself and FSC don't give double trigger at all.
Double trigger only given in antagonist cycle. If the previous cycle, if you had not got empty follicle, that is the only case I have given double trigger for IVF.
Dr. Pratik, lately we are getting a lot of articles where people have compared HCG trigger, recombinant HCG trigger with a dual trigger. Both the things are given simultaneously, and
Yes.
they have found less number of anti-follicle syndrome, and more number of metaphase 2 sites, more number of blastocysts. So this need to be validated in future, but number of articles are coming which are stressing that dual triggers are better than single trigger, either by agonist or by HCG. A lot of articles are coming up in last 5 years.
Yeah, so what I feel is when we are giving only the HCG trigger, we miss that small wave of FSH which is there with the GnRH agonist also. So that small wave of FSH is also very important. It improves the egg quality also, and it helps in more retrieval of oocytes also, like less chances of anti-follicle syndrome association. So if you are giving the HCG trigger, we miss that small FSH wave which we get with the agonist. So if I get giving both, I think in poor responders gives definitely a better result.
So Kanchan, you have to give us the data in a year. We'll call you back for the next journal club a year after this. So you'll give us data on it, right? Okay.
And I like to ask Abu Bakr sir, we were discussing about adjuvants. before you joined. And
Yes.
so I like to know your experience, sir, because I have little experience with the growth hormone and I mean testosterone pre-treatment. So what is your experience with that and with the DHEA or any other adjuvants which you routinely use for responders?
Really in Egypt, because of the cost is very important, and the growth hormone and the dihydroepinestrone also very expensive. Now we are, and there is no strong evidence that it is beneficial. We are giving the cheap, we are giving the bentixofillin, and we are giving the coenzyme 10 tablets as an adjuvant. And the nowadays, because of the expense and the cost, the giving growth hormone and the DHEAS is decreasing in Egypt.
So they are giving coenzyme Q. That's what he's saying, Dr. FOGSI.
Yes,
compared
we are
to
giving it.
DHA or growth
Sir,
hormone.
how long you will give before the stimulation, or how much, 300 or 100?
At least for 8 weeks, 2 months at least.
Okay, 300 or 300?
300.
300 OD for 2 months before the
Yes,
stimulation center.
Yes.
Any other adjuvants are needed, helps for a poor responder?
DHEA or
In the past, we were giving the DHEA, but nowadays, because it is very expensive in Egypt, we are giving it very rarely and not as a routine as in the past. We should consider the cost of the adjuvant.
So you are saying you are using pentoxifylline. So how do you use this pentoxifylline and for how long?
Yes, we are using it also for 8 weeks at least, and we are giving 3 times daily. And all of this, there is no strong evidence to support any one of this. We are giving the cheap, the easy one.
There's a question for Tanya Das. Tanya, can you unmute yourself? Yeah. They are asking like the gonadotropin requirement in a follicular phase stimulation compared to a luteal phase stimulation. Is the requirement same? Like, will you give more number of injections in the luteal phase? That's what they're asking me.
Ma'am, what this study has shown is that they are using the similar amount of gonadotropins when they are stimulating during the luteal phase as well as during the follicular phase, if they have used gonadotropin for stimulation. Otherwise, if they have used clomiphene and letrozole, the dose is same during the follicular phase as well as the luteal phase. The doses have not yet changed.
So the requirement does not come down at all. The requirement is does not come down. So there's no cost. Cost effectiveness is not there at all.
That's what the limitation is, ma'am, of dual stimulation.
Only
That they are using
different studies are telling different doses. That's all. Each study were using the same dose. That's what, no? Tanya, you are telling.
Yes, ma'am. Yes, sir.
See, you said that the agonist which is used for the trigger in the follicular phase stimulation helps in the luteal phase stimulation. That's what you said in your this thing. But then the doses should come down, or our requirement then, because this agonist it's helping in the growth of the follicle. No.
Ma'am, what they have said is that more number of oocytes were retrieved during the luteal phase because one of the possibilities could be that they have not concluded it.
Okay. Okay. And you talk, is there a use for using progesterone in the follicular phase, Dr. FOGSI, compared to ANTAC to reduce the cost of a cycle in a poor responder?
Pardon, I didn't get that.
See, they're using medroxyprogesterone acetate. They're using dydrogesterone in the follicular phase to reduce the cost factor. Is it worthwhile for a poor responder?
These are recent studies. I think first came about this 3 or 4 years back in the Shaper studies. I think we need a larger studies before we can tell any other data. Even I don't think any of the larger studies are there. Only very few studies are there.
Dr.
I have not started using it.
Yes.
Yes, and in fact, in the last case, we have used the progesterone primed stimulation only.
Okay.
Doesn't make much difference. Earlier, you can say 4 or 5 cases we have used antagonist protocol for the dual stimulation. And the last case which we did along with Dr. Saurav. Dr. Saurav, are you here?
Dr. Saurav, you can unmute yourself.
So what we did in the last case, we used the progesterone stimulation only and did not find any difference. But what this article has shown that in the luteal phase, the requirement of the FSH gonadotropins was equal. I have always found the requirement of the gonadotropin in the second stimulation is much lesser. Duration is also much lesser. We get much earlier dominant follicles, and second pickup is, you can say, on the 7th day or 8th day, patient is ready for the second pickup.
No, actually, I was not asking about dual stimulation. I was talking about the follicular phase use of progesterones for people with poor responders.
Yes, ma'am. Okay. Only for the lately we are using only the progesterone prime stimulation only. We have stopped using antagonist. In 90% of our cases, all of us are doing only progesterone prime stimulation, mainly because of the cost factor only. And not much of difference. Absolutely, no, we didn't find any difference.
And one question always usually strikes my mind, like when you use OC pills and go for an anti-cycle, will the response be poor?
OCP, after OCP, we need to give a gap of 5 days before we give stimulation. There has to be a wash-off period. This is a mistake we have done almost 10 years back when I first heard about the use of OCP. And I do remember this was in BHU, there was a AICOG conference. And the pre-Congress workshop, one of the international speakers was talking about OCP. And somehow in that talk, he did not talk anything about the wash-off period. And as soon as I came down from the AICOG, I used almost in 30 patients. And all 30 patients resulted into resistant stimulation. I won't say poor responder, but I had to stimulate them for 13 days, 14 days. And lately, immediately after that, within 2-3 months, a lot of articles started coming out. You need to have a wash-off period of 5 days if you are using the OCP. OCP has its own advantage, but nowadays, I think most of us are using the luteal phase estrogen if we are using anything.
Pratik, what are your thoughts on that? Pratik, unmute yourself. Please unmute Dr. Pratik, tech support. Dr. Abubakar, sir, can you?
Yes, I want to raise a point about the use of the progesterone primed ovarian stimulation in poor responder and even in normal responder, because in Egypt there is a shortage of the antagonists, and we are obliged to use this protocol, and it is now used in many centers, the progesterone primed ovarian stimulation.
We're actually talking about the OC pulse primed this thing, stimulation.
Yes, we are not using it, and if we want to regulate the cycle, we are using the progestogen alone for scheduling the cycle, and we are not using the combined oral contraceptive pills, especially in the antagonist protocol.
Pratik, what do you think on that?
So as far as OC pills is concerned, I think the largest experience or body of experience that all of us have is with OC pills. I'm sure older generation people like Cressy and me who've been in practice for 15-20 years. OC pills has been the pretty much standard way of regulating cycles and scheduling cycles, especially when you're doing batch IVF. Now, as far as OC pills advantages are concerned, of course, know that the scheduling of the cycle is easier. We are aware that you can generate a synchronized cohort, which is very much, desirable for us as ART clinicians, because we don't like different follicles at different sizes in the same primary as well as the secondary cohort. That is a nightmare scenario for us. But the fact remains that when you give OC pills, your consumption of ampules of FSH increases. The duration of your stimulation may be longer by 1 or 2 days, and you have to be mentally prepared that the cost per cycle is going to be slightly higher as far as the cost of gonadotropins is concerned. This is the disadvantage. The advantage, as I mentioned, is that you are going to have a nice synchronized cohort You will not have to spend sleepless nights. You don't need to worry whether your primary cohort 3 or 4 follicles, whatever I've seen, are going to give you good quality M2s or not, whether you should aim for the primary or the secondary cohort, which one should you choose from. All those nightmare scenarios are not there anymore. So that is the advantage of using OCP. But in clinical practice, I think most of us have now transitioned into estrogen or into progesterone prime stimulation. And the advantage of those is that they offer the same advantages as OC pills. Most of the time, the cost per cycle doesn't increase significantly. Most of the time, the duration of stimulation doesn't increase significantly. But again, there is a learning curve if you're transitioning from OC pills into progesterone or OC pills into estrogen. You have to find what works for you. As far as poor responders are concerned, most of the time they will come to you on the first or the second day of the cycle. They will not give you sufficient advance notice. So this discussion becomes a theoretical discussion. They will come to you on the first, second day of the cycle and say, okay, doctor, I'm ready now, please stimulate. So all the theory about transdermal testosterone, about DHEA, coenzyme Q10, all those things which we are discussing, that is for a very select group of patients who present to you well in advance. They are mentally ready. They have read a lot of things on Google. They are prepared to wait for 2 or 3 cycles before you run the index or the treatment cycle. But in clinical practice, the vast majority of patients don't fall into this select group. They'll come to you on the first, second day of the cycle, say, doctor, you please stimulate me now. I want to undergo a cycle.
Suppose you give progesterones and do a batch IVF, what will be the problem? You can give a progesterone only pill. That's what Dr. Vidyun Krishna is asking. That's a logical question, no?
You can do that as well, but then what happens is that your cycles may not be synchronized. Some patients get their period 3 days after they stop progesterone. Some may get it 7 days after they stop progesterone. And there is a wide variation between 3 days and 7 days. You can't run a batch with 5 days difference between the first patient and the last patient. The entire concept of batch goes out of the window if that happens.
See, when you use a OC pill, will you land up with an unexpected poor response? Does it happen often?
It happens rarely, and most of the times it would happen not because of the OC pill priming. It would happen more often because either your batch-to-batch consistency of gonadotropin is not there, or your cold chain maintenance is an issue. These are the two most common issues in the Indian scenario. These may not be widely mentioned in Western literature because they don't have to deal with all this. And the third one, which we are seeing more often now, is the issue of FSH receptor polymorphism. And this is much more common in Poseidon 1 and 2, where the patients are less than 35 and they have what we call an, in inverted commas, unexpected poor response. Of course, as was earlier mentioned by somebody, the FSH receptor polymorphisms testing should be ideally done for all patients who are poor responders. But then it's very...
You reminded us. So we'll have the third... No, we'll have the third presentation and we'll have the...
Yeah, there are very few places where it is actually done.
Done, yes. So we'll have the third presentation now and we'll have the discussion on FSH polymorphism. Can you have the third presentation? Dr. Saurav? Dr. Deepak is joined.
Actually, he should be like Saurav, are you there?
If you can show your video, we can unmute.
I will go to his chamber. I will check.
Okay. Pratik, please continue. He's joined. Dr. Deepak is there. Dr. Saurav, you can screen share. Kanchan, you can introduce him, please. Kanchan is frozen. Pratik, please continue. FSH polymorphism.
Yeah, so as I was saying, FSH receptor polymorphisms are something which we are encountering with greater frequency now in the last 5 to 6 years. This doesn't mean that they did not exist 20 years back. They did exist then as well. Probably at that time, we were not aware of this concept. We were not aware that this is something that we should be considering. We probably were not even aware that our own patients who we are seeing in clinical practice would have these issues. We just dismiss them as issues with the drug, its quality, or cold chain maintenance. But this is a very real issue. We are encountering it with more and more frequency in clinical practice. As was mentioned earlier during this ICOG Journal Club, the tests for that are quite expensive. They are not widely or easily available. But then that's something which we need to be able to offer to our patients, because they run around from pillar to post searching for reasons why there is an unexpected poor response. And therefore, we need to be able to offer real solutions and real advantages to these patients when they go for their next cycle. Now, if it is proven that this patient has an FSH receptor polymorphism, what are the actual modifications we can make in the next cycle? How do we counsel this couple? Whether we just change the drug, we change to a different preparation, a different company, do we advise recombinant to these patients? Do we add LH? Do we add other masala that we commonly advise our patients? Is it going to be beneficial or not? That's something that we need to discuss with this patient. And we need to manage what is called their expectation. They shouldn't be under the impression that, yes, if we undergo all these, then this time the cycle is going to be perfect. We're going to generate 7 or 8 nice oocytes. We're going to get 3 blastocysts at the end of that. It's very important to counsel these couples properly and manage their expectations right at the beginning. Because if things don't work out well at the end of those 13 or 14 days of stimulation, you're going to land up with a lot of aftermath to deal with, which you and I will not be mentally prepared. And that's why you need to have that conversation right in the beginning.
You gave a very nice introduction for the third talk, actually. That's going to be, yeah, it's going to be on the relationship between FSH receptor polymorphism status and IVF cycle outcome. It's a retrospective observational study by Dr. Kamar, and it's going to be presented by Dr. Saurav Maheshwari. May I request Dr. Saurav to present the article, please? You can screen share and start. Dr. Saurav? Okay.
Saurav, we can't hear you.
Dr. Saurav? We are not able to hear you.
Saurav, if there is a problem with the internet in your room, you can come to my chamber. Dr. Rosina is sitting there. You can bring your presentation in pen drive.
Dr. FOGSI?
Yes, yes.
So you were saying, sir, that FSH polymorphism, because it's expensive, you're not doing, but Pratik said if it's needed, can be done. Do you think if cost is not a factor, we can do it for the young, unexpected responder?
Definitely. I'm telling that I don't have a personal experience other than what you read in the articles. Okay. I just want to know from Pratik, how expensive is it, because it is not available. I have not done it here.
We can ask Dr. Abu Bakr, sir, whether they do in Egypt. Dr. Abu Bakr, sir?
No, we are not doing it in Egypt.
For the unexpected poor responder in a young person, what are your strategies, sir, to improve her response?
Yes, in this condition, we are increasing the dose than the previous one, right? And yes, we are trying in this condition to give the recombinant FSH, because it is mentioned that the outcome of the follicles is more than the HMG, and also try to give the adjuvant. That's all for the unexpected poor responder, or the type 1 and type 2.
Sir?
Sorry for the inconvenience. Am I now audible?
Yes, sir. Yes. Please continue, Dr. Saurav. We'll talk to Dr. Abu Bakr.
Thank you. Good evening, respected faculties, international and national faculties. And I am discussing today a topic which is less been discussed about, and there are very less literature on this topic. This is because of the reason that it does not deal with the treatment of poor responder, but rather the diagnosis of poor responders. So the topic from my journal is the relationship between FSH receptor polymorphism status and IVF cycle outcome, which was a retrospective observational study. I hope I'm audible to everyone.
Perfectly audible. You're audible.
Yes.
So we all understand that the success of IVF depends on the effectiveness of ovarian stimulation, and getting an adequate number of high quality oocyte is a major challenge. Ovarian response to FSH is sometimes difficult to predict, and it ranges from poor responders to hyper responders. We all know that there are predictors of ovarian response which have been time tested. Those are the clinical predictors, that is the age, the biochemical AMH concentrations, and the ultrasonic antral follicle counts. But with upcoming pharmacogenetics, a new predictor has now come up, which is the FSH receptor polymorphism status. So FSH receptor is essential. FSH is essential for oocyte maturation, and its physiological action depends on the activation of its receptor. FSH receptor is a G protein coupled receptor, which is expressed on the granulosa cells. It mediates its signals through cyclic AMP pathway. Gene polymorphisms modify hormonal function and their receptors, and the variability seen in patient response to stimulation could be attributed to single nucleotide polymorphisms. Most single nucleotide polymorphisms, or what we call SNPs, are present on the non-coding region of the gene, which is the introns. However, few are also present on the exons, which is the coding region of the gene. Till now, more than 2,000 single nucleotide polymorphisms have been reported with the FSH receptor gene. However, one polymorphism specifically, that is present in the codon 680 of the exon 10 of the FSH receptor gene, where asparagine is replaced by serine. This asparagine 680 serine polymorphism is almost always seen in a non-disjunction equilibrium with another polymorphism, that is 307 alanine, where at codon 307, threonine is replaced with alanine. However, most of the studies, in fact, 99% of the studies have discussed only the asparagine 680 serine polymorphism variant. So in 1995, Aitomaki et al. First described the three genotypes of the asparagine 680 serine. Those were asparagine-asparagine, asparagine-serine, and the serine-serine genotype. Whereas Moiraga et al. In 2000 first evaluated the role of asparagine 680 serine in relation to ovarian stimulation, and they reported a higher basal FSH level and elevated gonadotropin requirements in the serine-serine variant. FSH receptor gene genotype is an important factor for determining the prognosis of ovarian stimulation cycle, was this conclusion. Similar findings were reported by Sudo et al., De Castro, and other authors throughout the years. However, multiple studies also suggested no association between the FSH receptor polymorphism and ovarian response. Meta-analyses were also not conclusive. These contradictory and inconclusive findings possibly could be due to small sample size and heterogeneity of the studied population. The article which I have chosen is a very recent one, which was published in the RBM Online, Reproductive Biomedicine Online, which has an impact factor of 4.567 as of 2023. It was presented by the author, Dr. Tamar Koenig, who obtained her medical degree in the VU University in Amsterdam, and she's presently working as an IVF in the IVF department in the same university. So I will directly come to the objective and outcomes of the study. So the primary outcome of the study was live birth rate and ongoing pregnancy rate. And the secondary outcome were the number of mature follicles on the day of HCG trigger, the total number of gonadotropins used, the number of retrieved oocytes, the number of embryos, and the top quality embryos. It was a retrospective observational cohort study, and patients were selected with electronic patient database from a single tertiary IVF center. The total number of patients included were 1185, and the study duration was January 2008 to March 2012. So only women with between 18 to 43 years were included, and only the first IVF ICSI treatment cycle were included. And all the women whose FSH receptor polymorphism were determined, only those were in the included patients, and presence of both ovaries. However, any previous unsuccessful cycles oocyte donation cycles, surrogacy cycles were excluded from the study, and azoospermia was also excluded. The genomic DNA was automated isolated with biorobot, and FSH receptor polymorphism determination was done with RFLP and with PCR. Day 2, the basal FSH was measured with immunometric assay, and estradiol was measured with radioimmunoassay. All the 3 major protocols, that is the long GnRH agonist protocol, short agonist protocol, as well as antagonist downregulated cycles were used. The author specifically used the long-term pituitary downregulated cycle in the ASRM stage 3 and 4 endometriosis, and downregulation was given at least for 3 months before IVF FOGSI cycles. The standard statistical package was used for the analysis, and the data were compared by Kruskal-Wallis test. The logistic regression analysis was done to compare the cumulative live birth rates between the different receptor polymorphism and were corrected for confounders. A p-value of less than 0.05 was considered significant. Now, the results for genotype frequency distribution was as follows. The asparagine genotype was seen in 28% of the women, asparagine serine in 52%, and the serine variant was seen in almost 20% of the study population. Of all the basal patient characteristics, only the basal FSH level was considered to be significant and was seen higher in the serine group. Out of all the patient out of the primary outcome, the live birth rate was least in the asparagine group, which was significant. However, the cumulative live birth rate in the 3 genotypes were not significant. The total duration of FSH administration, the total dose, the endometrial thickness, the E2 levels, and the number of follicles, matured follicles, were not significant. However, the number of oocytes retrieved, the number of mature oocytes, as well as the number of embryos were significantly less in the serine group. They divided the patients into subgroups of according to the response, and to poor responders, normal responders, and hyper responders. The criteria being less than 4 retrieved oocytes as poor responders and more than 20 as hyper responders. And the number of the subgroup in poor response and hyper response were found to be significant in the 3 genotypes. The poor ovarian response group was obviously found to have been treated with higher number of gonadotropins compared to normal responders as well as over responders, which was same in all the 3 genotypes. However, no significant difference was observed in the total duration of stimulation among the 3 genotypes in all the 3 subgroups. So the overall duration of stimulation was similar. They've also done a SWOT analysis of their study. And coming first to the strengths of the study, this cohort study was the first study to investigate the effect of polymorphism on the live birth rates. They included only treatment-naive cases to minimize the heterogeneity. It is in fact one of the largest studies till date to investigate the relationship between the asparagine-serine polymorphism and ovarian response. Out of the total 2,137 patients who presented in the primary database, 1,303 patients were undergone the polymorphism testing, out of which only 1,185 were chosen because it was the first IVF cycle, and complete follow-up till the cumulative live births was done in all the cases. Coming to the weakness of the study, it was a retrospective study, and the progesterone level was not determined on the trigger day, which could have led to the which would have influenced the primary endpoint, that was the live birth rate. A premature elevation of the progesterone may have affected the implantation and hence lower live birth rate. Now coming to the threats, the asparagine variant had a showed in the study had a significant lower live birth rate per embryo transfer compared to the asparagine serine variant that was in the fresh transfer. However, logistic regression analysis, adjusted or unadjusted for age, found no difference in the cumulative live birth rate. A possible explanation could be that in the poor responder groups, the high ovarian stimulation could have caused the higher level of estradiol, which could have disturbed the endometrial development and receptivity, leading to a shorter period of implantation and hence a decreased pregnancy rate. Such negative effect of the ovarian stimulation is not present in the subsequent frozen embryo transfer cycles. Hence, the cumulative pregnancy rate would have was not significantly different. So finally, coming to the opportunities of the studies, the difference in the basal FSH level, along with the lower number of retrieved oocytes in the serine group, plus the similar FSH dosage used in all the 3 genotypes, show indeed that the serine variant has lower sensitivity and lower FSH responsiveness. So will the lower sensitive serine variant benefit more with the milder stimulation with a natural modest response, resulting in a better quality embryo and thus a higher live birth rate? We need more further RCTs in such patients where they can be randomly allocated to different stimulation protocols, and a proper stimulation protocol can be tailored for these poor responders. Thank you.
A very good presentation, Dr. Saurav, giving us lots of food for thought. May I ask Dr. FOGSI to give us inputs before we move on to Dr. Abu Bakr?
Can you stop sharing?
Dr. Saurav, please stop sharing.
Yes.
So, I think as we discussed already, this is under research level. I have no access to do this. That's why I wanted to ask Pradeep whether he is having access to do that FSH polymorphism in Mumbai and what is the cost involved. As far as my knowledge, largest study in India is done by Ramraj sir from Andhra Pradesh. He has been doing for last 4 years. So I think I don't know whether he has published the data. Otherwise, and he was doing it regularly for many patients, but I don't know whether he has published it. Otherwise, I have no access. I want to know the input from Deepak, Pradeep, and Abu Bakr sir.
To my knowledge, it's not being offered in Mumbai as of today.
But it is a promising thing. When the larger data is there, I think really we can explain to the poor responders as Pradeep when patient ask what was the reason. So most of the times we are not able to explain. So in those cases, it will be useful.
It's being offered in Belgium because they have a large cohort of these poor responders and they have drainage from all over the world. Nearly 5,000-6,000 cycles in a year. There it is definitely being offered, but as of today, I don't think there's any place in Mumbai where it's being offered. I may be wrong. Do correct me if I'm wrong.
Dr. Abu Bakr is there in Egypt? Dr. Abu Bakr, sir? Dr. Deepak, you got an access to the testing?
Yeah, few of the inputs I can share. I do remember our last HR conference at Hyderabad. There was a free paper, and
so your audio is not clear. Can you come a little bit near the device? Yes.
I do remember in our one of the HR conferences at Hyderabad, there was a free paper about this receptor polymorphism. And I asked the author at that time, and they told they have a laboratory out there in Hyderabad, they do it. One of my students, Dr. Durga Vatalye, she also, I had a discussion with her also from Hyderabad only. She was also doing this test regularly. And after that, the COVID came. During the COVID period, we tried to find out, but couldn't find out, as Dr. Pratik told that it is not available. And 3 months back, again, we got some interest in this particular polymorphism. Again, I asked all the laboratories, such as LifeCell and Lilac and all other laboratories. All of them told me they are not doing it as an isolated marker, but it is a part of clinical exome sequencing. So it is available in all the laboratories available in India, whether it is a Lilac, whether it is a LifeCell, or any other laboratory. Just you have to ask for the clinical exome sequencing, and you have to specify them. You want to look for the FSH receptor polymorphism also. So we all understand the cost of this polymorph, this exome sequencing is somewhere between 20 to 25,000. So we will get this test available with all our patients anywhere in India if we go for the exome sequencing. But if we are looking for a specific marker, it is not available. We have not done it. So far, we have not done in our center in any of our cases, but definitely we are motivated to do, and hopefully next year we will share our data.
Okay. Suppose the number of oocytes are less, but will the embryo, this thing is quite good, Pratik. She may be having a poor response, but if she is young enough, will she have a good embryo?
Ultimately, it depends if this patient is one who has an unexpected poor response at an age less than 35, because the gonadotropin that we are administering is not binding to the receptor. Ultimately, if your gonadotropin is not going to work, whether you use recombinant, you use highly purified, whether you add growth hormone or any other adjuvants, the final common pathway is through the receptor. If the receptor is not going to function, then your number of oocytes as well as quality of oocytes and the presence of what we call as aneuploidies within those oocytes is going to be significantly higher. Therefore, that translates into poor results. But again, I would like to restart that conversation where we said that now we know that a certain number of follicles is required to generate one euploid embryo. In a younger patient who is less than 35, generally you will be able to generate a larger cohort of follicles. Ultimately, they will give you at least 2 euploid embryos per started cycle. Whereas in an older patient who is more than 35, after all your manipulations, you may not be able to give them 1 or more good euploid embryos per started cycle. That is where you need to have your freezing, you need to have your embryo pooling or your oocyte pooling to give you good results. In a younger patient, by and large, with 1 or 2 cycles, you should be able to generate good euploid embryos and give them.
Thank you so much. I think we are reaching the time to finish. I would like the inputs from all the experts before we go on to the conclusion. Dr. Deepak, your thoughts on all the 3 papers?
I think all the 3 presenters did a wonderful job. This is a very important topic we all face in our day-to-day clinical practice. And as Dr. Pratik told, we don't have a clear-cut answer for all the questions. Long way to go forward, but these are the new things we can look forward. Dual stimulation, very limited experience, though articles are coming. Again, for the FSH receptor polymorphism, till now we didn't know how to approach for it, how to go for it. But now we know that it is a part of exome sequencing. So we can start doing all these things and offer to our patients. And we will definitely learn. And regarding the first talk by Dr. Rosina, Poseidon criteria, it is a definitely very good step to move forward and helping us in our day-to-day clinical practice in counseling the patients.
Yes. Dr. FOGSI?
As in a nutshell, if you tell that the Poseidon criteria will, the first paper will tell how you classify the poor responders, how you can anticipate poor responders, especially in those 1, 2 classification where we can, and in the previous responders or when we expect, and according to that we can counsel the patient. That is one good thing. And secondly, in dual stimulation, in few cases which are really needed, as told, and it is not to be routinely used for all poor responders. That is a second paper. And third paper about polymorphism is a promising thing where we can tell the patient why it was poor responders, and large studies in future, as Deepak told, if we can do in India, if it can do in many labs, we can have very, very large data about poor responders, and that will be helping future modifying the stimulation protocol in patients with poor responders.
Thank you so much, sir. Dr. Kanchan, you're unmuted. Tech support, please unmute Dr. Kanchan, please. Pratik, we'll have your thoughts before we move on to Dr. Kanchan. On all the 3 papers, all the 3 papers.
We begin by thanking both Dr. Charmila and Dr. Lakshmi Shekhande for organizing this excellent journal club. Responders is a topic which generates a lot of controversy. There's a lot of heartburn. All of us have had a lot of experiences with these patients. Some of them are expected, some of them are unexpected. We each have our own ways of dealing with these patients. We had 3 excellent papers looking at 3 different aspects of poor responders, how to manage, how to strategize, how to offer them the best alternatives. All the 3 presenters did very well. The choice of papers was also excellent. Very high quality program. So congratulations to all the presenters, the conveners, and ICOG, of course. Thank you for giving me this opportunity. We've touched on all the important aspects from clinical management point of view. One is to stratify the response of the ovary. Second is to classify the patient into the correct slot, class 1, 2, 3, or 4 as per Poseidon. What are the individualized treatments that we can offer the patient? And finally, at the end of the day, I think we talked a lot about cutting edge technologies, which may still not have matured, but hopefully over the next few years will help us and our patients, help us to give our patients good. Thank you again for having me.
Thank you, Pratik. Dr. Kanchan?
Yeah, ma'am, first of all, I would like to thank FOGSI ICOG for this journal club. It was very good. We have learned a lot from this journal club today. I would like to thank all the presenters. They have presented very nicely. And now this poor responder is more relevant in today's scenario with the ART new law coming up, where we have only one donor giving for one patient and cannot donate again. So now we have to, whatever patients come to us, we cannot think of a donor right away. We have to think of the other way out. Those poor responders only, how we can improve their result, how we can give them pregnancy. So whatever we have discussed today regarding the androgens, the antioxidants, these are all ways which will help us to move ahead and to give pregnancy to these poor responders also. And regarding the FSH polymorphism, yes, definitely it helps us, because sometimes when we are getting in unexpected, if we are getting a poor response, and definitely we have seen that in next cycle, if you are using a better gonadotrophic rec FSH with a higher dose, we are getting better results. So of course, this topic is very relevant in today's scenario, and in future, if we can do this for all the patients, it will really be very helpful for us. And the Poseidon criteria is of course helping us a lot, because what we have seen is even in the expected poor response, the one who is a younger patient, they give us better oocyte, they give us better embryos than those who are in the older age group. So in comparison to the Bologna criteria, the Poseidon criteria is definitely helping us a lot. So that's why I thought we chose these 3 articles today. And I think the presenters have also done a very good job, and we have learned, all of us have learned a lot.
So we are actually relying on you for good data, new data in the future. Okay.
Yeah, sure.
Dr. Abu Bakr, sir, your inputs before we close the session. Dr. Abu Bakr, sir is there? Okay. So I would like to just say that the summary of all these 3 papers, for the unexpected poor responder, for a younger patient, what I learned from these experts is you change your gonadotropin, change a brand or the company if you're using that regularly, check for the cold chain, probably increase a dose in her next cycle. If the cost is not a problem, add rec LH, rec FSH. Is that right, Dr. FSC, whatever I said? For the unexpected poor responder who's young. And for the unexpected poor responder in an older patient, actually you should have expected. Even if a result test is showing normal, it may not be normal as it's showing. So that may be a expected poor response. And the growth hormone, according to Dr. Fesi, which is the group of patients who will benefit, the younger or the older patient?
Older patients.
Older patients will benefit more from growth hormone. Please think twice before going for dual stimulations after reading so many articles, journals, and papers. All that may not work out for that patient whom you are trying. So see the data, look through more papers, articles before you try that, because still it's not accepted even by SRA. Embryo pooling is also still in the research phase. And regarding the type of gonadotropins, if cost is not a problem, I think for all these patients, you should have gone for a recombinant FSH, because the cold chain and the quality will be much better. Like anything else anybody would like to add before we close the session? May I ask Dr. Lakshmi Shrikande madam to join the program, because it is entirely her efforts. She's such a great academician and she gives us a free rein, and it's always an honor to be in madam's programs. Thank you so much, Lakshmi ma'am. Maybe have your thoughts before we close the session.
No. In fact, I should thank you, Charmila. You are doing a wonderful job, and I also learned a lot from all these experts as far as poor responder is concerned. So well done, and let's look forward to having our next month's journal club. You can announce the date and the theme for next month's journal club.
It will be done by Jipmer Pondicherry. It's going to be an obstetric topic. It will be in the second Tuesday of next month, April 9th. It will be. And thank you so much for joining. And I'm extremely honored and I'm thankful to Dr. Deepak Goenka, who's taken such lots of efforts. And we could see you running from room to room. You made so much of effort that it will work out. And we know that these type of network issues happen in most parts of the country, but you made such a great effort, sir. I'm extremely thankful because we learned so much from this session. And as Dr. FOGSI said, all the articles were thought-provoking and each was so contributory to the learning of every participant who joined. And special thanks to Dr. Kanchan, the young Kanchan, whom we are putting so much hopes on. Next year, we'll want her data so that you present original data for us next year. Thank you, Dr. Kanchan, for all your efforts. And I'm extremely thankful Dr. FOGSI Lewis was taken his precious time to and share his thoughts because he does such good original work on infertility and IVF. And Pratik, we don't have any words to thank you. You are always a trendsetter and you give us such good inputs. Thank you so much for joining. A special thanks to Dr. Abu Bakr who's joined from Egypt. I think sir is joined now. Sir, your inputs before we close.
I think
yes, thanks a lot. It was a very kind
invitation.
And it gives me great pleasure to share with you in the next meeting or next scientific journal clubs, inshallah.
Yes.
The question, we wanted to know your experience with polymorphism before we conclude.
No, we don't have any experience with the polymorphism.
That's the thought for the day, sir. Finished.
Yes.
They don't. Yes, sir. I'd like to thank the presenters, Dr. Regina, Dr. Tanya, and Dr. Saurav. You did such a great job. Thanks to our dear Neelima from ICOG, whom we always trouble, but she always puts up the best efforts. And thank you, Neelima, for that. And tech support, Mr. Jignesh. Thank you so much. Dr. Deepak, yeah, thank you.
Thank you for the opportunity.
Thank you.
Jignesh, you can stop the recording and end the meeting. Yeah. See you all, dear.
Thank you, ma'am.
Bye bye.
Bye, ma'am.
Bye.
Bye.
Thank you.